Welcome to the Functional Medicine Doc Talk podcast. I'm your host, Dr. Kurt Woeller, talking with experts in functional and integrative health and medicine, discussing critical information for improving your health and wellness to help you live a long, full life. Let's get to it. Hi, everybody. This is Dr. Kurt Woeller. Welcome to the podcast. This is part 2 of my discussion with Dr. Pejman Kitiraei. Dr. Katiraei is an integrative pediatrician. He's also an osteopathic physician, which is, I went to medical school to become an osteopath as well. And so we are kindred spirits, not only in our training as osteopaths, but also in the autism world. So we're going to continue a conversation that we had in part 1. In part 1, we went through mold, mycotoxins. Dr. Katiraei talked about dampness. We talked about microglia and mast cells and microbiome. So if you have not listened to part 1, I'd recommend you go listen to part 1 and then obviously come back to this part 2 discussion for this very important topic with regards to mold mycotoxin and how it relates to autism and other individuals with special needs. So, Pejman, welcome to the program.
Thank you for having me and creating this conversation.
Or maybe I should say welcome back. So we wrapped up part 1 talking about laboratory testing, some of the tests that you like to do in your practice. You talked about different blood testing for IgG reactivity, IgE, allergy sensitivity, or allergy reactions, and then IgA, some of the labs there. Real quickly, and then I want to move into the importance of home inspection. But where does the organic acid test for you fall into your practice? And what about urine mycotoxin testing? How do you incorporate that information?
Absolutely. I love organic acids. I do it on every single child. I think this is your domain, so I know you love it too. I think there's so much valuable information that can come from it. When it comes to assessing fungal imbalances, and especially mold exposure, it has to be used with a degree of caution. Because what I have found is that its false negative rate when it comes to assessing fungal imbalances and especially exposure to mold is about 50%. So 1 in 2 times the child has been exposed, they have significant gut issues. There are all kinds of odd anomalies, and for whatever reason, which I do not understand, the fungal component of the organic acid, presuming we're doing Mosaic or Genova, but Mosaic is my favorite, it comes back normal. And I've had kids where, we found out they were living in a moldy environment. The kid had all kinds of odd sensory issues, immune abnormalities, etc. First test normal, second test normal, third test somewhere around 16 months later, still in the same environment, suddenly highly abnormal. And this has happened multiple times. So I love the organic acid tests, still recommend them and use them all the time on literally every single patient with that little caveat, because the fungal component, when it's positive, it's very useful, and it's usually very accurate in predicting that there has been exposure, especially when Aspergillus and even some of the non-specific fungal markers, minus arabinose, come up positive. But the other, the false negatives are there. Urine mycotoxins, I have stopped using altogether. I have found them to be very unreliable, and this is across the board with all the companies. There are times that you get significant false positives because of food. So peanuts, gluten, dairy, dried fruits, they're all moldy foods. And they can contribute to the findings on the urine testing in a pretty substantial way. Their false negative rate, so the number of times they miss mold, is also significant. I've had kids way too many times, horrendous amounts of exposure. Kids were living in homes that should have been condemned. Urine levels didn't look terrible. Like sometimes you see one peak where you look at it, you're like, that doesn't look bad. It doesn't look like this child is being exposed. And then the environmental testing or antibody testing, which we discussed before, comes back and it shows a very, very different picture. So over time, even though I was trained to use them, and I spent probably 3 or 4 years with, probably 500 plus kids where I was using them extensively over and over and over again, I just found the urine mycotoxins to be very unreliable.
So one of the things that I want to impress upon people is to understand is that there typically isn't that one perfect test, in all circumstances, although there are certain tests that are, much more able to capture, a exposure or an underlying biochemical problem or imbalance, or the story, for example, of some types of, metabolic imbalance, for example, problem. The classic example is heavy metals. There's no one perfect heavy metal test because heavy metals get compartmentalized in different parts of the body. You can have it circulating in the blood. You can get into different tissues. And so a lot of times you have to do different types of tests to try to determine the existence and the presence of it. And I think the same types of things can occur, Pejman, with just environmental exposures, for example. Obviously, some of the immunological tests that you do are very, very specific as far as the immune system being reactive and engaged. I often look at the mycotoxin test like I would look at a urine profile for environmental chemicals or glyphosate. They're tests of detection of exposure, and they give you an idea of exposure. But they may not necessarily always be indicating a very high level or how much somebody may be detoxifying, for example. And I've had similar circumstances where the mycotox urine test really didn't look that bad, but the clinical picture looked terrible. And this is one of the things that we've talked a lot about, and some of the forums we're on, and the organic acid training that I've done in the past, and I've listened to, read a lot of your posts and whatnot too, and is that you always, always, always have to apply the lab to the clinical, presentation of the individual, because you're not treating the lab per se. It's what's the collective nature of this individual, the symptoms, their exposure, their family history, and how does the lab test apply to them? You can't solely rely, typically, most of the time, on just one test. And I would agree with you with regards to the organic acid test. Amazing test. I love the test. It's an absolute go-to in my practice. But you may not always find high levels of colonization with regards to the aspergillus markers. And there is no marker on the organic acid test for Stachybotrys, for example. So you have to expand your view. And I often look at lab testing. The analogy I give is if you go to Yosemite Falls or you go see the Statue of Liberty, right? You're not going to take just one photograph. You're going to take a photograph from afar, from up close, maybe off to the left-hand side, maybe from behind. You're going to get you're going to take a lot of different photos to give you this broad three-dimensional view. And that's something that you often get when you start incorporating different types of testing, perhaps when you're looking for these types of exposures. So anyway, that's my view, but I appreciate that. Let's move into, okay, we've established that there is exposure. And in the world of mold, in the world of mycotoxins, and let's just throw in this concept of dampness. There are some elements within the integrated functional world that say you need to get out of that environment, and because it's poisoning you. But first off, you need to confirm that where the exposure perhaps is coming from. I've had situations where a child was being exposed to mold at their school, and it wasn't really their home. So let's talk about inspection. So just a general overview of what should people be considering when it comes to home inspection, and then maybe even other exposures from a mold mycotoxin standpoint that you've seen in your practice.
Well, if we could backtrack for a second, because I think you touched on something that's really important, which is really creating this whole picture. And I think part of that whole picture is the history, which a lot of times, both families and a lot of our colleagues overlook, right? So part of this clinical picture is really understanding details in the history. And there's really two typical scenarios that I see when it comes to dampness and autism. There's the baby that's born into a moldy home, and then there's a child that was actually doing fine, and then they move into a moldy home at some point later in life, and then they start having issues. So the latter one is actually kind of a little easier to really dissect out first. And this is typically child was doing great, right? A little common cold, a little whatever, but nothing huge. They were doing fine socially, developmentally, talking, connecting, interacting, etc. Child moves, and then usually within a 1 to 6 month period of time, so it's not always immediate, and that's something really important to highlight, child starts having issues. They start having coughing. They start having respiratory issues. They get ear infections. They get a pneumonia, and then all of a sudden they start changing, all of a sudden being over sometimes multiple months. This piece of clinical data is actually really, really important, and I can't highlight how often little details like this get overlooked, and somehow the other providers didn't see the correlation between the move and this child becoming sick. To your point, I've seen schools be horribly contaminated. 20% of all schools have mold. So for the kids who were doing fine and now suddenly have learning issues, and they've got sensory issues, and now they're struggling to connect, and they're anxious, and they're irritable. That could be mold from the school. Usually in these scenarios, there are other kids that are having issues too. So one kid has severe ADHD now out of the blue. The other kid is having asthma attacks. The other kid has had 4 ear infections in a 6-month period of time when they didn't have it before. So these are all very important clinical findings that if anyone pays attention to, it'll start highlighting the issues. To add to that, a lot of times when the exposure is happening in the home, one of the things that happens is one of the two parents start having odd things. And sometimes the parents start completely falling apart, but most of the time, because the adults have more resilient systems, it just shows up as, yeah, I just feel tired all the time, and I sleep, but I don't feel refreshed. I've got brain fog, I've got memory issues, and this, along with congestion and coughing and whatever else, are oftentimes very strong telltale signs that there's some kind of environmental exposure, aka dampness, that's causing this. A baby that's born into a moldy environment sometimes presents as initially they're having colic. So it's not, oh, the baby's crying and fussing for a few minutes. It's like intense, multiple hours per day, crying. You can't console them. You have to drive them around because otherwise they will not fall asleep. So they're already hyper-vigilant, hyper-aware, so that hyper-parasympathetic response. A lot of times these kids will start having gastroesophageal reflux and vomiting. They're developing food sensitivities. Mom has to cut out gluten, dairy, corn, all kinds of things. Then baby gets eczema. Then they start having other problems. So all of this is actually early signs of exposure that I see commonly in the kids who ultimately go on to have a regressive event later on. And part of what really drives me is if we can catch it before that child's system has completely fallen apart, we may be able to prevent so many cases of autism because we're catching this entire toxic inflammatory event before the child's system has fallen apart. So I want to highlight that because to your point, building that bigger clinical picture is something that I don't think we do often enough.
Very interesting about the colic, about some of these other things. I think about some of the kids with, at least in my practice, I see from time to time is the, eosinophilic esophagitis. I mean, that to me would be something kind of classic to this type of exposure. And we could have a whole other discussion about kids, women who are living in a moldy environment, who then get pregnant, who then, there's some studies out there that talk about how Aspergillus may even be colonizing some of these kids, maybe perhaps even triggering immune tolerance to some degree. So there was a paper that came out, I think it was in 2019. We've discussed this before, and then that's a whole other layer of complexity. So clearly we know that these exposures and these funguses are quite problematic. By the way, real quickly, a quick story on the school. So when my son was going into third grade or fourth grade, we showed up day one to meet the teacher. And I noticed the teacher, this is a woman probably in her mid-30s, just had a flat effect. There was really just a bit cold, but not really personable. I mean, nice, but just there was something off that I felt. And I walk in the room to the classroom and I'm like, something's not right in this. I thought I could maybe smell a little bit of mildew, but it was kind of chaotic. They had to get the kids going in class and whatnot. About a month later, we go for a sit-in. And we're in the class, and I can see the teacher is struggling to convey her message to the kids. And there's, a bunch of kids sort of distracted. And then I could smell the mold. So make a long story short, it turned out that we went to the school, we transferred our son out of that room into another classroom of that school. And then the school themselves had somebody come out and admitted that there had been a water main break over the summer. And there was 2 classrooms that got water damage. It was Aspergillus mold. And eventually, about 3 weeks or so after we transferred our son out, he was in that room for about 6 weeks. The teacher went to the school and said that the room was making her ill. The other thing I noticed, she had a tremor. So she almost looked like she had early onset Parkinson's. And eventually, she transferred out of that school, went to another place. They shut down that particular building, the 2 buildings where there had water damage. I think it took them the rest of the year to fix it. But it was like, because I had seen this kind of thing with some of my kids in my practice, and then there it was just with my own son. So my sense of that woman and that teacher was that she'd probably been in moldy environments for years throughout the schools. You're mentioning 20% of schools, for example, and this was in Southern California. So you imagine what some of the schools are like back east, in the South. I know that in hurricane areas like Florida and Texas, it could be problematic. I know they've had big issues in Houston, for example. So pretty interesting. Okay, so real quickly, just your advice to somebody who is trying to do some type of in-home mold assessment. There's a lot of different companies out there that offer up lab testing. What are some practical things that a parent can know to sort of strategize, optimize the capture rate of mold spores for them going through this process?
Really good point. So I think the first thing is what we touched on earlier. I've lost counts, probably in the thousands now of families that have, we've done the testing and the testing is suggesting there's mold. And then the family's like, well, we had our house tested, we don't have it. So if you've had a conventional inspection done with a little air sample test, you cannot rely on that to rule out mold. What I have started doing is really the most effective screening. So this is not definitively ruling in and out, but the screening tool is basically something that's very sensitive that either says, is there a problem or not? And if there is, then we need to check into it further. And for a screening tool, I have found this DNA technology to be the most effective way. So they conventionally call it the ERMI test, Environmental Relative Moldy Index. And basically what it is you take a Swiffer pad, you gather dust, a lot of dust on the Swiffer pad, you send it to the lab, and the laboratory basically runs a DNA probe looking for fragments of mold within the dust that don't belong there. Because if you get big spikes of Stachybotrys, there's another mold that, like you touched on with Stachy. Stachy is very sensitive to water, like you said. Chaetomium is another very toxinogenic mold that's also very, very particular to water levels. If humidity levels fluctuate, Chaetomium doesn't like to grow. When you see big spikes of Chaetomium, Stachybotrys, and there's a handful of other ones that are also very sensitive to humidity, it becomes a flag that there's potential for problem. Of all of the companies that run this DNA probe, there's one that I like the most that's called literally the Dust Test. No financial affiliation with them. Why I've come to like them is on the front end, they give more information in terms of how to do the testing. And then on the back end, they make the interpretation insanely easy. So with the other herbies, like you have to look at the molds and the numbers don't always correlate. With the dust tests, and they have someone reviewing each and every single one. It's either like 1 through 5, 5 being the worst of the worst, the top 10% of all contaminated homes. 4 is you may have a mess, it's not 100%. 3 and below is like you're golden. One of the things I tell all families that do the dust test, and about $270, is to not dust or clean for about 7 days before. Because I've seen a lot of families where they kind of do the test, but they don't allow enough dust to settle. Dust test looks fine, except there's mold because there wasn't enough sampling. So I tell everyone, don't clean or dust for about 7 to 10 days. Let dust settle, and then follow their instructions to gather a ton of dust from all of the different environments, and then send that off. If the dust test comes back suggesting that there's a problem, now you've got to bring someone to figure out where the heck it is. And this is where you have to be really careful. Most, again, conventional mold inspectors, some of them are very good, some of them are not. There's a website called ISEAI.org, International Society for Environmentally Acquired Illness, that actually has a list of environmental experts that, for the most part, 98% of them are actually really good, and they're very invested in actually finding it. So now you can then step up. One of the other things that I've recently found to be really helpful, and this is kind of funny, is actually mold dogs. I don't know if you've ever heard of the mold dogs.
I have not.
We have one in Southern California. There's one in Northern California. I know there's a few on the East Coast. Basically, these are dogs that are trained to sniff out mold. So, I mean, when you think about it, these volatile compounds that these organisms produce, these microorganisms produce, have a weird smell to them. We human beings can kind of smell them. It turns out that dogs are actually really good at smelling this stuff. So these dogs just go around the house and they're trained specifically to look for that musty smell. So they'll go up to the walls and just kind of, do their thing. And then the owner's like, well, you may have mold here. And then, they just go around. And then that actually makes it easier because now you can bring a conventional inspector and say, can you check this wall? Literally, like poke a hole, get a sample from here to then confirm that there's something. So that's typically how I've started structuring the inspection, which dramatically increases the accuracy. And also, when there isn't an issue, controls costs because $270 is better than $2,000.
Yeah. Great information. Very interesting. It makes sense with the dog. They can smell a lot of things, so they use them in other ways as well. Before we move on to treatment, $1 million question. I have mold in the house. I feel like I'm sick from the mold. My child the same way. Do we need to move? Do we need to throw out our clothes? Do we need to get rid of all of our furniture, particularly cloth furniture? What's your perspective on that? Because that's something that comes at quite a bit in this space with regards to mold mycotoxins.
That's been, the conventional, if you want to say, mindset in the mold community. If you have any mold and you're sick, you need to move, you need to clean, you need to throw everything away because there's no other way to deal, which, I quickly realized was not realistic. Right? I mean, if you've got, a bunch of money or you're really, really, really sick and you have horrendous levels of mold, right? Like you do the dust test and it's like code 5 and like the levels of Stachybotrys and whatever are really high, or there's been obvious like water events and multiple leaks and you've got water stains everywhere. Like there are certain cases where it's like, that home is beyond, like you can't live there until everything's cleaned up. Outside of those most extreme scenarios, I find that there are a lot of times we can actually heal within the home if people take certain steps to control the environment. Because, part of what I strongly believe is because there's so much of this, right? Again, 1 in 3 to 1 in 2 people are exposed. It's not realistic to try to remediate every home. It's not realistic for every person to throw away everything. Minus if there's a lot of mold and families do move, mattresses are the one thing that I suggest people replace because usually there's stuff in there. But part of what I've tied my treatment protocol with the environmental piece is really my treatment protocol actually becomes my gauge of how bad are things. So as part of the treatment protocol, what I started doing, this has been about 4 or 5 years now of me tinkering and fine-tuning things, is I use a combination of literally 4 supplements, period. There's a product called Mirica, Mirica. Again, no financial affiliation with any of this. Mirica is a combination of PEA, which is essentially a fat extract from eggs that happens to be fairly good at stabilizing mast cells, especially within the gut. It has some properties against the microglia, which is more where a lot of the brain inflammation comes from. And it also has luteolin, which is a bioflavonoid that also helps with the gut and the brain inflammation. We add to that an enzyme that we naturally have that breaks down histamine called diamine oxidase, or DAO enzymes. Multiple companies make it. Seeking Health is one of the ones that I use, but I mean, they're all kind of the same. And then I add some vitamin D and zinc. Why I do that is, first and foremost, you get rid of citric acid, you get rid of all things. Fish oils can sometimes trigger issues. Probiotics can sometimes trigger issues. Other compounds and things can cause issues. So I take the children to a very simple place. With that, at the very least, I have families get rid of food coloring, sugar, preservatives, chemicals. If they can get rid of gluten and dairy, fantastic. With some of the kids who are intense, autistic, sensory, those kids, it's really hard to move their diet because they just fall apart. So I have the families do what they can, but we basically start the supplements. And I give these kids about 3 or 4 weeks, typically while I'm waiting for the test to come back to see how they respond. If with these basic supplements, the parents suddenly find the kids have less self-injurious behavior, they're more calm, they're sleeping better, they're less reactive, they're less overwhelmed, that's a fantastic sign. That's generally a sign that the immune system of this child is not pushed over the edge to the point where we have to be more worried about the environment and, also the diet and the gut. The kids who actually take these supplements and they get worse, that's actually a sign that their immune systems are so dysregulated that there's usually other things provoking that immune system that we now have to kind of step up our game in either controlling the immune system or paying closer attention to the environment. And this is where, I want to highlight the environmental piece does play a significant role, because the analogy I've given to families is, imagine your child's autistic presentation is essentially, as Dr. Katiraei brilliantly said, is a brain allergy. So he termed the coin brain allergy. So if your child's sensory issues and aggression and irritability and sleep problems and some of the self-injurious behaviors are a brain allergy, except your child is, let's say, arbitrarily allergic to peanuts, but they're in an environment where there's peanut dust everywhere, right? And they're constantly getting exposed to this peanut dust, constantly having an allergic reaction, which is constantly driving their symptoms. Then in that case, we have to control the environment. And why I bring this up is I would say one of the things that I see really lacking in our community, so of holistic integrative pediatricians and providers, is a lot of these really wonderful, well-intending, well-trained, smart people have not had the training on the environmental piece. And I look at the trainings that are out there, there's a lot of discussion about treatment, very little discussion about the environment, except if mycotoxins can trigger brain inflammation, then maybe we need to control the mycotoxins to control the inflammation. So far, so good?
Yep, excellent.
Great.
Yeah.
So,
and this really segues into, from a treatment standpoint. And I think you really actually just kind of highlighted the question I was going to ask was prep work prior to antifungals, whether that, is nutritional supplementation or other support interventions, dietary changes. I mean, that could be an entire discussion in itself, but I like the fact that you really just try to keep it simple, but your method for doing so is also you're doing detective work because you're using the interventions that you're using, even though they're certainly maybe minimal as far as the amount of things you're giving compared to some of the other protocols out there, but you're also using them very strategically to see how a child responds, positive, negative, and then making a determination from there about what that might mean. So one of the big things in this type of medicine is everything we do and everything we implement is done based for a specific reason. And you might have a positive response that says, aha, that tells me this. You might have a negative response, and that's another clue to look elsewhere or to additional tests or other types of scenarios. And, again, none of us live in a bubble. So there is always going to be other types of exposures that we're exposed to, and the same thing with kids and same thing with the parents. And that always has to, I think, come into play in consideration. So let's get into the nitty-gritty of we have a confirmed problem. We're now going to move forward with some type of antifungal intervention. So are you of any more in the mindset of, we really need to just go straight to medications, or we might get some movement with botanicals, maybe combination of probiotics? I know I'm kind of throwing at this at you from a simplistic standpoint, because in reality, what it really comes down to is the individual child themselves, the circumstances, the family dynamics, all of that come into play. But I'm going to throw that question to you anyway, just so we can open up this conversation, and I'll probably have some things to say as well. So let's say you've made the decision, you've done all your testing, you got all the information back. Okay, we're moving forward from a general standpoint with intervention.
Yeah. So if I can actually just backtrack for 1 second, I want to touch on one other piece of the environment, because I think that this is important. There are some easy things that don't break the bank that people can do to actually control exposure. So presuming someone's not living in horrific levels of mold, there's a technology called ionization. There's a specific company called Air Oasis, no financial affiliation with them, that actually combines carbon, which pulls up the volatile compounds, HEPA, which pulls out the mold spores, and ionization, which actually controls the particulates, that can actually be used to some extent to control the exposure. So in moderately contaminated homes, that this filter, along with a deep cleaning protocol, and we inspect, actually, if you go and do a search, they actually have a deep cleaning protocol where essentially you are HEPA vacuuming, microfiber wiping the walls. So you're removing as much dust and particulate out of the environment as possible. You're getting rid of the stuffies. You're getting rid of any and all clutter that would trap dust. So by dusting the heck out of everything, including the ceiling, wall, floors, and running these filters, what we're able to do in cases where it's not completely dire is you're able to control the environment further, removing all the peanut dust particles, essentially, to minimize the amount of immune activation. And when this works, you've got a child that becomes more stable, right, behaviorally, aggression, irritability, which then actually becomes essentially the foundation that I use to start moving into the next phase.
And I appreciate you bringing that. I'm glad you went back to that, because I kind of skipped over that, and I shouldn't have, was that you said pretty much what I thought you were going to say when it came to the aspect of there's mold, you need to move, right? I'm in agreement with you. It's not practical for everybody. Yeah, there are certain circumstances where a home is so damaged, so compromised that that's what needs to happen. But there's got to be a workaround. There's got to be other solutions, and it really comes down to, in many cases, different patients, different scenarios, different things that could be done. And it's nice to have these other options to think about: cleaning, air filtration, et cetera. I kind of look at these types of situations as, what can we do to lower the stuff in the allergy inflammatory bucket, right? And the more that we can do from cleaning our environment to air filtration to reducing inflammatory foods to all of these things just lowers the bucket. And so when we can lower the stuff in the bucket, we're going to become less reactive, and that's the way these kids are, so that they can get a more profound response to an antifungal and perhaps not be so reactive. Because, I mean, you've seen it, Pejman, I've seen it. There are some kids that, you can give them, I don't know, I'm just throwing it out there, 20 different things, right? And they handle it just fine. You give some kid, 10 milligrams of vitamin C or, a little bit of B vitamin and their world falls apart. So they're so super sensitive. So again, I appreciate you mentioning that. And, okay. So we've sort of established the fact from testing to things to try to assess the home to confirming problems. Let's talk about intervention, antifungal.
So with the antifungals, I want to first start with kind of giving a little preface. I spent 4 years training as an herbalist, and I mean, to this day, we have a herbal pharmacy in our clinic that has 120 or so different, tinctures, gemos, mother tinctures, etc. So, I grew up in my medical practice becoming obsessed with plants. What I found for these kids, much to my dismay, is their ability to tolerate most botanicals is quite poor. And, I've tried every herbal antifungal under the sun. And what I found is for a lot of these kids, they were just either they became very reactive to them, and literally 2 drops of whatever tincture was making them go completely nuts, or I would treat them for 6 to 9 months, and then afterwards look at their lab results and, frankly, clinically, and nothing changed. So, much to my dismay and many heartbreaks, I've come to this place which is actually very different. So I want to highlight that because what I want to share now is not because I just kind of willy-nilly jumped into this domain. When children are in a stable place, and this is, I believe, fundamental, so meaning they're more calm, they're less reactive, they have less sensory issues, they're starting to eat more, they're making a little bit more eye contact, that is a sign of immunological stability. If they have that, when you introduce antifungals, those antifungals, the pharmaceuticals, could be dramatic in their way of helping these kids. When these children are not stable, it's like you're walking through a landmine zone, and with every other step, another limb gets blown off because immunologically, that child's ability to tolerate most things is still extremely poor. And as an extension of this, when that child is immunologically still unstable, either because of diet or usually it's because of ongoing environmental exposure that has not been controlled, I've had some cases where children were put on 6 weeks of fluconazole, itraconazole, whatever. They did get better, and we're going to touch on, I'm sure, why these medications help. They did get better, but then pharmaceuticals stopped, child is exactly back to where they were, and that's because all of the exposure that was driving the inflammation, all the stuff we talked about in part 1, was never effectively addressed, and the child's system was still as reactive as before. So that's kind of the backdrop to kind of where the next conversation comes. Should we dive into the antifungals? Or?
Absolutely. Go for it.
So for me, I generally like to start with, so child is stable, and now the conversation is, how do we start healing their gut? For a lot of the kids I found, and I'm still, I've gotten pretty good at gauging it, but there are some times where I'm still not sure. I always start them with nystatin. Nystatin is the weakest of the weak antifungals, but it happens to be one of the best tolerated of all of the products that are out there, including the botanicals. So I've had kids that have gotten whatever combination of antifungal botanicals, 2 to 3 drops, they're completely losing it. You put them on nystatin, and they actually start doing better. With the caveat that regular prescription nystatin, if you actually look at the ingredients, there's like red dye 40 and multiple preservatives and chemicals, which are actually problematic. So getting it through a compounding pharmacy where there's less additives, which makes it better tolerated, is generally a good idea. So I start the kids on nystatin, and I have about 20 or 30% of the kids that just with simple nystatin, they start making more eye contact, they start becoming more engaged, they're calming down, they're actually starting to do better without any fancy stuff. And nystatin just gets rid of candida, and get rid of is kind of a loose term. It controls candida, period. And that just is, I think, a beautiful reflection of how much these fungi are impacting these poor kids in their immune system and their nervous system that we tend to sometimes miss. From there, if the child did pretty well with nystatin or there was no change, I usually take them to just straight to Itraconazole, which is, frankly, one of my favorite treatments out there. A lot of times people look at Itraconazole as antifungal, which it is. It's a broad-spectrum antifungal that kills candida, but also aspergillus and most other molds. One of the things early on that I started realizing in the kids was that the rate at which they were changing was way too fast for Itraconazole to be working as just an antifungal. So I'm sure you've had many kids, you treat their gut, and over usually 2 to 4 months, the kids start doing better. With some of these kids, literally it was within 2 weeks of starting Itraconazole, eye contact, sociability. There was one case that I'll never forget. Mom gave the kid maybe 3 or 4 doses of Itraconazole, and the kid turns to the mom for the first time, like essentially in the kid's entire life. He's like, "Mom, I love you." And both the mom and I, when she was sharing that, like my jaw dropped, I started crying, she started crying. I've had other kids where all of a sudden they're way more connected to their siblings. Or in my own experience, when I took it, it was probably 4 or 5 doses in, like I literally could feel my entire brain chemistry changing. And that is after multiple of these experiences. I said Itraconazole isn't just behaving as an antifungal, and I talked to my mentor like Neil Nathan and others, and they're all like, "Yeah, this thing is doing more." It turns out that Itraconazole has some rather dramatic and profound immune modulating properties, to the point where I would say Itraconazole is first and foremost an immune modulator, and it actually controls the immune system as its primary mechanism. And as a secondary effect, it's really the antifungal piece, which is the killing off fungus and getting rid of things.
That was one of the things, is you've done some really good online lectures where you talk about things that we talked about like in the part 1 interview, the microglia, mast cell, inflammation, etc. But you had some really compelling information you came up with, some of your research about Itraconazole acting as an immune modulator. Can you get a little bit more specific about some of the influences from a molecular standpoint and what's happening physiologically, biochemically with Itraconazole, whether it's downregulating microglia, whether it's having some, modulating impact on pro-inflammatory cytokines? What are some examples of this immune modulation effect of Itraconazole beyond its antifungal properties?
Yeah, absolutely. So there are a lot of studies out there that are actually exploring if you kind of expand out, it's not just Itraconazole, it's all the azoles. So there is clotrimazole, there's fenbendazole, there's a lot of these different classes. Some of them are actually antiparasitics, but it turns out that essentially this azole ring that they all have itself has really interesting immune modulating properties. And there's a lot of research happening, especially in the cancer world, looking at how these compounds are flipping on and off certain switches that happen to be very effective in certain cancers. So one of the things that Itraconazole and other azoles are very good at is modulating this cellular signaling pathway called sonic hedgehog. Most people think of that as the cartoon character, But it turns out that sonic hedgehog actually is one of the most important cell regulating pathways out there. And I know you've written on it, on how it actually is profoundly important for cellular growth and development and so forth. So sonic hedgehog, when it's properly regulated, does a lot. And on one hand, it is very important for everything from preventing neural tooth defects, proper neural signaling, the blood-brain barrier, cellular development, cellular growth, and a lot of things that ultimately come to creating a human being. When sonic hedgehog is when it's under kind of activated, it can cause neural tooth defects, and I know you touched on this. And when it's overactivated, it actually can trigger all kinds of rather complex inflammatory events, including disruption of the blood-brain barrier, including massive upregulation of the microglia and triggering all kinds of neurologically pro-inflammatory cascades. And I believe one of the primary mechanisms in which itraconazole is actually helping these kids is probably through modulating the sonic hedgehog pathway and down-regulating this pro-inflammatory event. And it turns out that, for instance, when you have excess NF-kappa beta, you have other things that can upregulate sonic hedgehog, which mycotoxins can induce. So in a way, itraconazole is kind of counterbalancing that, and then through that, probably helping bring the blood-brain barrier back, down-regulating the inflammation in the brain, which we touched on in part one, and causing a lot of issues.
So one thing I just want to and that's fascinating, as just a quick reset for people out there who, aren't really maybe into all of the technical, molecular biology and reactivity kinds of things here we're getting into. But it's important to understand that the structural integrity of the lining of the digestive system and some of the protein components of it are very similar to the lining or what make up the blood-brain barrier. And so you can develop a leaky gut. You can also develop a leaky blood-brain barrier. And that's problematic because coming from the gut, we want to absorb nutrients and other beneficial compounds, but we want to keep certain toxins out. Well, there's going to be certain things that make their way into the bloodstream, and we try to keep those out of the brain. And so the blood-brain barrier acts as a barrier against bad stuff getting into the brain. And the problem is when the blood-brain barrier is breached, you have those immune cells, those microglia sitting there as the primary immune cell within the brain that react, become active, and they can generate inflammation. So the fact that the itraconazole has a stabilizing influence on the blood-brain barrier, there's other things that do as well, but the fact that the itraconazole is known to do that and has a modulating effect on the sonic hedgehog pathway, I didn't realize that it had such a profound effect from a pro-inflammatory standpoint, Pejman, when it is overactivated. I'm curious in your research, because we talked about, you mentioned about azoles, so that could be itraconazole, that could be fluconazole. So have you come across diflucan having a similar effect?
Yeah, I have. And I think one of the reasons why diflucan is actually helpful for a lot of the kids is the same thing. Why I like itraconazole, even though it's a little bit harder to get sometimes based on insurance, is if you stand way, way, way back, right? You have the 2,000-foot view of autism. You say, well, autism is essentially a combination of brain inflammation, leaky gut inflammation, and all kinds of microbial imbalances within the gut. And is there one tool that can simultaneously hit all of these things at the same time, including ultimately getting rid of the aspergillus, which happens to have a very significant role in activating the mast cells and triggering gut inflammation, which fluconazole can't? That's where itraconazole comes in. And part of my intrigue with this pharmaceutical is, unlike botanicals that can really just affect, the gut or whatever, and some botanicals obviously have more complex behaviors. what's so fascinating about this pharmaceutical is we're essentially downregulating the microglia, probably downregulating the mast cells through kind of secondary mechanisms. Itraconazole has been found to, in certain models, actually reduce gut inflammation. So in certain cases of aspergillus-inducing colitis, full-blown inflammatory bowel disease, they found that itraconazole was effective in putting that colitis model in remission, which is crazy. So it reduces gut inflammation, improves gut integrity, gets rid of the candida and molds, while I believe simultaneously stopping the spread of acid on the lawn, right? Going back to our part one discussion, if someone's spraying acid in your lawn all the time, all the weeds start coming out. If that acid spraying on the lawn is now stopped, the beneficial bacteria now have an environment that is actually conducive for their growth. So the bifidobacters, the lactobacilli now actually are able to repopulate, whereas before I believe they couldn't. So we're essentially changing the entire milieu of the gastrointestinal tract while reducing systemic inflammation, while reducing CNS inflammation. And so far, in all the digging that I have done, I have yet to encounter any compound that's actually able to do that all at once.
Really fascinating. Quick story, and then I want to get into a little bit more about some things from different dosing regimens. So years ago when I was practicing in Southern California, as you know, California has forest fires, right? You're in Los Angeles, so you just had a major one. And the Santa Anas, they kick up with the Santa Anas as the desert winds blow from the desert towards the Pacific Ocean. So this particular circumstance, there was an autistic child, I forget the age, it was the age now, but very severe. And he was fairly well regulated with diet, and they were using the family was using periodic antifungals, probably mostly botanicals, but stable, but still severely autistic. San Diego has a forest fire. The fire rages from the mountains of East County, San Diego, towards the Pacific Ocean. And within about 2 days of the smoke completely obliterating most of San Diego County, North County anyway, I got a phone call from this family where the child had gone from fairly well controlled to smearing his feces all over the bedroom and all over the bathroom. And I thought, okay, I don't have time to do an organic acid test. It's going to take, a week and a half to get that back. Botanicals aren't going to touch this. And I thought nystatin is not likely going to touch this either. This is a systemic reaction. At that time, I didn't know about itraconazole, so I prescribed diflucan. Within a couple days, the smoke clears. Within about 48 hours of the diflucan, the child's behavior of smearing his feces stopped.
Wow.
And I've always assumed, right, that, it was just a major reduction in the fungal load. But as I'm sitting here listening to you talk about the fact of using itraconazole, going, wait a minute, I'm seeing this, I'm seeing that. There's some other mechanism happening here. It's not just an antifungal. And so now as I think about that particular case, when I think about the azole reactivity and some of the mechanisms, it was likely having an immune modulatory influence, probably more so than an antifungal influence. So very interesting. There's a lot of ways of approaching dosing. If you look up some of the traditional literature on itraconazole Sporanox, for aspergillus, it's, 100 milligrams, twice a day, or 200 milligrams, et cetera. I think it's 200 milligrams once a day. Beyond that, you kind of do a split dose. But usually it's for a couple weeks. Some of the more chronic situations, they'll go on for multiple weeks or a little bit longer. But we're typically working in a world where the exposures are quite profound. The colonization, if you want to call it that, the immune reactivity is long-standing. And so usually, in my experience, using some of these antifungals for just a week or two might move the needle a little bit, but it doesn't do much. The kids typically regress. So what are some approaches that you have found, because you're dosing things a little bit differently than what is even maybe within the tradition of integrated functional medicine or in the world of biomedical intervention, you've come upon a pattern in the way you're dosing the itraconazole that I find quite intriguing. Talk about that.
Yeah, so, the first thing, if you ask, just like with the bacteria, the bacteria got play a very important role in regulating the system. It turns out that now special properties in regulating the immune system, and they are important in really informing the behavior of the immune system. So one of the questions for us to ask is this idea of nuking the gut. So, like there's the paper by Dr. Sid Baker and Shaw, which I know you're familiar with, where they push doses up to 600 milligrams per day, which is super therapeutic, which produced a remarkable result. And I believe that the reason why they got the full regression is actually because of the anti-inflammatory effect that they were creating, not because they were just killing off fungus. So they basically pushed itraconazole to a super high dose, caused massive anti-immune modulating or immune modulating effects, calmed down the immune system, which actually caused that healing of the child. But if we say, well, God, what happens if we push itraconazole too high or we give it every day? One, can we start killing off, some fungus that in the long term, 5 to 10 years down the road, would actually be necessary for regulating the immune system? We don't know. And the other part that you have written about, and I touched on, is pathways like sonic hedgehog are kind of a double-edged sword. If you over-suppress these pathways, which itraconazole may be able to do, you may actually start disrupting cellular pathways that down the road we will come to find to become a problem. So as I've looked at all of this, what I started realizing is doing high doses, even everyday dosing of itraconazole is perhaps not a great idea. And when you are meticulous about making sure the environment is relatively clean, the child's diet is pretty decent, take care of iron deficiency, zinc deficiency, parasites, there's lots of parasites, those could become the, basic things. Take care of basic things. At every other day dosing, starting at 5 milligrams per kilo, which is, the pounds divided by 2.2, up to 100 milligrams. So I don't even go usually above 100 milligrams unless the child is gigantic, basically full adult size. I find that children respond remarkably well to that pulse dosing. And the outcomes that I see where children are interacting, making eye contact, engaging with peers, all of their sensory issues, all of their behavioral issues, irritability, calm down, or entirely gone is possible without the potential risk. And, the other part is, as a pediatrician and dad, every time I suggest a blood draw to a family, I think of would I want my daughter or son to have a needle stuck in them to check something? And the answer is if you have to, you have to, but it's not something any parent wants. With everyday or high doses of itraconazole, we start running also into issues of liver toxicity, especially, and that's where relatively frequent liver monitoring becomes an issue. And while I always get the baseline set of liver enzymes starting and always try to check one 4 to 6 weeks out, generally what I find with this pulse dosing is we don't get into toxicity because of that. So I believe with relatively low doses of pulsing itraconazole, we can get all the benefits without the potential short-term or theoretical long-term consequences that come from the other dosing regimens.
What's a typical duration of use that you're seeing in your practice by doing that every other day?
I typically go for 4 to 6 months. And I found that if you go earlier, a lot of times when you stop, the children tend to fall back 2 to 3 months later. Part of what I'm now looking to do is by adding biofilm disruptors, whether they're enzymes or if the kids are doing really well, adding botanicals on top of the itraconazole, more for the antifungal biofilm disruption, using peptides specifically for more of an anti-inflammatory effect within the gut. Are there ways where I can speed up the healing process or really solidify the healing process so that when itraconazole disappears from the picture, because you don't want to put the kid on the itraconazole for the rest of their life, that benefits will hold? And so far what I found is 50% of the time we stop itraconazole about 4 or 5 months out. The kid does fabulous, they're doing really well, and then another 40, 50%, the kids unfortunately regress. And I think those are the kids that I just haven't been as effective as needed in really healing their gut. But I really want to highlight, I believe that we're looking at this picture wrong in the sense of we need to nuke the fungus and the mold, and by getting rid of the mold is how we're healing the kids. Really, at the end of the day, the conversation needs to become, how do we get this child's gastrointestinal tract to become as healthy and resilient as possible, which has to do with improving the microbiome, reducing gut inflammation, reducing leaky gut or intestinal permeability. And that's where I think if we add things on top of the itraconazole that are complementary, once the child is stable, we can probably speed up the healing process. And that's actually part of what I'm now kind of doing side-by-side trials, putting some kids just on itraconazole, some kids on peptides or enzymes or whatever else to see which ones do better faster.
But I'm assuming in all of those cases that you're doing that with, there was prep work prior, right? There's testing, there's home cleaning, there's, trying to minimize, decrease the bucket, so to speak, of what is in that allergy inflammatory bucket. There's dietary changes. This is not a scenario of, a parent should just run out to their pediatrician and say, give me 100 milligrams of Sporanox without doing prep work. Because you're doing the Miraca, you're doing zinc, you're doing vitamin D, you're doing some prep work. And I think if I'm hearing you right, that prep work is incredibly important as a precursor to implementing the strategy.
100%. I think, a lot of families report, well, I tried that and it didn't work, or I tried it and my kid got sick. That is when people are not meticulous about setting the stage. It's like you're trying to build a house, except that house has no foundation, literally has no foundation, and you're trying to put up some, walls, and the walls keep falling. You have to set the foundation, and you have to be meticulous about this foundation, because otherwise, are there some cases where it'll still work? Yes. I think 20 or 30% of the time, if you just randomly throw it into a child with autistic features without doing anything, there'll probably be some benefit. But I would also say there's a much larger percentage of times where it will not work or the child will flare, and that's because all the other things were not properly put into place first.
100%. That's exactly what I've seen over the past many decades doing this. There always has to be prep work. This is the foundational aspects of trying to, as you describe, I like that, set the stage so that these things have a chance to actually work better and reduce the potential reactivity, the die-off reactions or the detox reactions or whatever. I've seen this even with heavy metal detox, Pejman. Many years ago, it was all about high-dose DMSA, ramp up the dose. And what I've seen to be more helpful over time is to be patient, implement a strategy, create the foundation, and then use lower dose types of things over time, giving that child a chance to adapt their biochemistry to equalize, for them to become not so reactive. It also gives the parents some comfort, too, to know that their child isn't constantly in this up and down scenario. And in some cases, the ups can be quite traumatic. We know it can be, in some kids, quite destructive. So really, really interesting. So as we kind of bring this conversation to a close, what are some action steps that families can take, some take homes from this, things that they can research, things that they can look into? this particular interview, as opposed, and the previous one is going to be on Spotify, and this will certainly get shared. But, are there certain resources that you want parents to have access to, things that you've created, for example? Maybe there's other books that people could read that you share in your practice to kind of help educate parents about these concepts.
Yeah, I want to add one thing first, which is one of the things that I found with this discussion that we're having is when parents put these things into place first. So when we stabilize the immune system, improve the gut, what I've also found is other things like leucovorin, folinic acid, B12 injections, et cetera, work remarkably better. I'm actually having conversations with my friend, Dr. Katiraei, about some of this in terms of how do we strategically map out when protocols are put into place. Because I find a lot of families have also tried, big doses of B9 and folate and so forth, and they don't find it to work. And in those cases, it's not because the treatment wasn't appropriate, it's the timing of it wasn't appropriate. When a child's brain is on fire, right, when you're highly inflamed, leucovorin cannot work because literally that poor child's nervous system isn't able to receive it. But what I've also seen is in the kids who we put them on Itraconazole and whatever else, and they're doing much better, and they see it, and they're calm, they're making eye contact, they're engaging, then you bring the folinic acid and B12, and then all of a sudden it's like the child just blossoms and they open up and they're interacting even more, and now they're talking and so forth. So there's a way to put all of this together if we just kind of look at what are the building blocks to allow us to take the next step and so forth. So I just want to...
By the way, I have seen that. I just want to interject. I've seen that too for years. In fact, many years ago, when I first recognized this pattern, there was always a subset of kids that did really well with methyl B12. So injection, nasal spray, and some of them, quite profoundly. And then there was a subgroup where you're like, well, they should respond. They have the same issues as the other kids that did. How come they're not responding? And it wasn't until their underlying fungal problems were addressed. And this, by the way, wasn't even always just mold. It could just be a really bad candida problem. And again, many years ago, the mold component wasn't as well recognized or appreciated as it is today. But it wasn't until they were on some type of antifungal intervention. It could be nystatin, maybe that was diflucan, maybe it was a combination of nystatin and botanicals. But the bottom line was, once you went through that for a couple of months and came back to the B12, then all of a sudden, things started to take off. So to your point, in fact, it was interesting you brought up leucovorin because that's clearly in the news now, and everybody's asking about leucovorin. And, although that information about leucovorin has been around for years, but to your point and things you brought up is just on the leucovorin standpoint, it's not needed by everybody. And there's going to be a select amount of kids that it doesn't really do much because there hasn't been prep work done. All the things that you've been talking about. So go ahead. Let's wrap this up. So any other points you want to make, action steps, words of encouragement?
Yeah. So
go for it.
I want to start with this, which is I can't even begin to count the number of parents who are seeing their kids struggle and fall apart. And the suffering that I see, and I'm sure you too, day by day, kids falling apart, just the awful, awful struggles that are out there. There is a solution, and not to say that dampness and mold is the cause of every child's autism, but there is a possibility that a very significant percentage of why these kids are so inflamed and they're struggling and they can't function and so forth is because of this. So, part of what I hope is that every parent at least considers this as part of their child's workup. And it's not complicated. One single blood test, one single home test is easy to do. And with this, there's a lot of information that can then come to light. Does anyone want mold? No. But at least if you find it, now this may explain part of why your child continues to struggle, why they're not progressing with everything else that you're doing. And it creates an opportunity to understand why some of the challenges are there. So I believe every child who's presenting with autism, especially severe cases of autism, should get one of these antibody tests and ultimately have the dust test done of their home, especially if a parent has some brain fog and fatigue and so forth. Two, part of what my intention at this time is to make this information as accessible and scalable as possible and hopefully get it into the hands of every family. So I created this Substack with this intention. It's all free. Everyone can access it. There's no charge. And in the Substack, there's actually very detailed protocols that any patient can use or any family can use with their provider that literally walks them through step by step. Here's the tests to consider. Here's what these tests mean. Here's the way to look at the environment. Here's how to prioritize each and every step, specifically because I want every family whose child is struggling to be able to access this. And it doesn't have to be complicated. Like there's a lot of complexity to it, but as you've seen with Dr. Woeller and I, you don't need to worry about all of the complexity if you look at some of these high-level views of why the complexity happens. And by addressing key areas of inflammation and toxicity and so forth, there's so much benefit that can come. And like I touched on, I mean, I've had kids who were totally disconnected, aggressive, irritable, self-injurious behavior, couldn't go to school, couldn't function in the world. And with a few steps and literally 4 to 6 months of treatment, totally calm, sleeping well, eating well, interacting, making eye contact, going to school, and now engaging other kids at school. Like some of these kids still can't articulate very well. They can't carry a conversation. They still script. But now they're actually wanting to engage with others, which is incredible. And all of this is within reach. Like Itraconazole, you can get with a prescription. Like these supplements are not expensive. Like all of this we can do if we just start understanding how this fits into the picture of why these kids are struggling.
What's your Substack?
It's Katiraei, so Substack, I think /PKATIRAEI.
Okay.
I'm happy to share with you the link.
Yeah, we'll have the link in your bio on the webpage for these interviews. How about your practice? Do you have a website?
Yeah, it's Holistic Kids, WHOLISTICKIDS.com.
Awesome. It's been a pleasure. Thanks so much for joining me.
You're most welcome. I'm thrilled that we were able to collaborate.
Fantastic. Well, thank you.
You've been listening to the Functional Medicine Doc Talk podcast with Dr. Kurt Woeller. For more information about this podcast, go to functionalmedicinedoctalk.com.